series. I am Dr. Edwin Michael, and I'm an epidemiologist at USF. And it is my pleasure today to present this panel discussion featuring Dr. Shireen Madon from the London School of Economics and Dr. Moses Katabarwa from RTI International. And we're going to today start speaking about an important topic, which is beginning to rise to the fore in global health governance. And this is the role of community agency in global health programs. But before I start and introduce the speakers, as well as introduce the topic, there's some in-house rules that I need to mention. First of all, this session is being recorded and will be can be accessed on YouTube, but this is also going live on YouTube. Secondly, just a brief statement on the format of this conversation. Following my introduction, we will have two presentations, one from Dr. Madon and the other one from Dr. Katabarwa. And hopefully those presentations will be in the order of 15 minutes each, after which there will be a panel discussion among the three of us. And then at the final 15 minutes, we will open the discussion up to the audience. Now, the audience can start putting in your questions already as the speakers present their work into the Q&A box, which you'll see at the bottom of your Zoom. The Zoom page. So you can start writing your questions. This will be monitored, and we will try and answer as many questions as possible. So before I begin the topic or introduce the speakers, a brief comment, why do we need to look at community agency? Now, the ongoing COVID pandemic has shown us, has raised to the fore, the issue of, governance in public health programs. Questions have been raised, as all of us know, about decision-making in delivery of public health programs. And if you see what has happened in the pandemic, we have seen that many governments have imposed, programs in a very top-down manner, which are expert-led, with very little input from citizens or from the public. And yet this is the public, that had to bear many of the consequences of those, top-down decisions which have been made. Now, if you'll see, if most of us will know that in the global north, this might be a special response to a global pandemic. But if you look at health programs in the global south, you'll see that this is the norm. Decisions are always made, top-down, led by experts, and with very little say from the public. This has raised a lot of questions. For example, the historical basis of why government-led programs are are a feature, of public health programs in the global south. I mean, there are historical reasons for that, but it has also led to some very perverse features of global health delivery in the South. You'll see one of the features is that many of these programs are internationally developed, and states are simply used to deliver these programs in a very strict top-down manner. This has raised questions about sustainability of those programs. It has also raised questions about the fit of these programs to national needs. And it's also led, as I said, to very perverse incentives generated around meeting of health indicators, which are normally set at the international level. So recently, people have started looking at how do we improve or reform this kind of health programs in the global south. One of the issues or topics which has really come up to the fore is, engaging the community. How can we bring in the community and its perspectives into health delivery by the governance? And today we have two, prominent speakers, and we're very lucky to have them come on to this conversation series. The first one I would like to introduce is Dr. Madon. She's a professor at the London School of Economics. She did a PhD in informatics and social development in the global South, and then has transited into looking at humanitarian issues and governance of humanitarian crisis. And lately, she started looking at governance structures around public health delivery in the global South, in particular India. And I'm hoping she will begin to, in her presentations, give us a short introduction into the theory of the need for community agency in global health programs, and also speak a little bit about mechanisms of how we can engage the community into health programs in the South, based on the work in India. The second speaker that we have is Dr. Moses Katabarwa. He's very eminent in neglected tropical disease control across the world. He's currently a senior anti-D technical advisor to RTI International, and previously he was also one of the directors of the lymphatic filariasis, onchocerciasis, and schistosomiasis programs at the Carter Center. Dr. Katabarwa is an anthropologist by training, and he's been interested in looking at exactly the topic that we are speaking about. How do we engage the community into the delivery of anti-D programs? And he's been instrumental in developing what is known as the community-directed treatment with ivermectin program in Uganda. It started in Uganda. Dr. Katabarwa is a Ugandan. And subsequently, that program of engaging the community in the delivery of this, of the intervention was taken up by WHO and is now a feature of all onchocerciasis programs in Africa in particular. As I said, he's an Ugandan, and many of the work that he's done has been also adopted by the Ugandan government, and community engagement is a serious part of many of Uganda's public health programs. Now, with that introduction, and without any further delay, Dr. Madon, can I ask you to come on and give your presentation? First of all, thank you for accepting our invitation. The floor is yours.
Thank you very much. I'm just about to share my screen. Can this be seen?
We can't see your screen yet.
You can't see my screen? Okay, 1 second. Now?
Yes.
Yeah?
Yes,
Yeah.
yes, we
Okay,
can. Thank
brilliant.
you.
Okay, well, thanks ever so much. I'm delighted to be here. And thank you very much for the introduction as well. It's true that there's been decades really of interventions which have been aimed at decentralized health governance. It's not a new thing. You know, there have been efforts to put in place structures, systems, using technologies as well to decentralize health governance, particularly for primary health care. So it's not a new phenomenon. There have been so many efforts. And yet we find that these interventions have not really resulted in improvements in terms of access and the quality of primary healthcare. And here we're talking about healthcare which is targeted at the most peripheral level and also intended for low-income populations in developing countries. A lot of these interventions aimed at decentralization have more recently been put across in major policy agendas under this banner of health systems resilience. So we find a lot of documents by the WHO and other global agencies with the aim of trying to decentralize, but in terms of efficiency and effectiveness of programs. And there's no end of data-centric approaches, having kind of dashboards which are available for policymakers, providing a kind of a snapshot view of outputs and outcomes, but not really giving much of an understanding or improving understanding of how the data is synthesized and how it is made relevant and actionable at the local level. I think this came to the fore, particularly following the Ebola crisis, where a concept known as everyday resilience emerged in the global health literature. And we found articles which are trying to characterize what does this mean? Because resilience it means many different things. And whereas this had been approached from a health systems point of view, for the first time post-Ebola, there was a discussion of this idea of everyday resilience, something that's different, something which emerges as a process of engaging the community. And it means that you need to impart capabilities for reflection amongst the local actors.
Sharon, can you go on to presentation mode?
Yes, I can. Sure.
Yeah. Thank you.
The thing about the Ebola crisis, of course, was even though there was a concerted effort to work with this concept of engaging the community, it was short-lived because a lot of the interventions were externally driven and externally funded, and so they were pilot projects which ended. So what I'd like to talk about today are some of the mechanisms for creating through experience, for creating this notion of everyday resilience, and how this absolutely has to be integrated within the existing institutional arrangements within countries. It cannot be externally imposed. And because it has to be integrated, and because we are talking about mechanisms, we begin to see through the case I'm going to talk about in India, how it is an undertaking that normally takes about a decade or more. So I'm going to try to move forward with this concept of everyday resilience and try to give it meaning through what I have learned and what I continue to study in South India, in the state of Karnataka. And this is really the following on from the experience of the Indian government's village health, sanitation, and nutrition committees. It's a bit of a long phrase, but it's the VHSNCs, which were established some time ago now in 2008 to promote intersectoral collaboration for the prevention of waterborne diseases such as diarrhea, typhoid, and cholera. If you look on the right-hand side of this slide, it's just a graphic to kind of explain what these committees, which were established formally by the central government, what was their shape, what was their structure. Now, these are supposed to be semi-autonomous committees in that they receive funding from the central government. So they're still part of, well, yes and no, we can talk about that later, but they are supposed to be formally part of the health apparatus of the country, but they are also autonomous in that the various members of this committee have got decision-making autonomy. So very briefly, on the right-hand side there in the graphics, in the red, you will see a variety of members who are politicians, political representatives, and they are villagers themselves. Whereas in the green, we see that this committee is constituted by functionaries, a variety of different functionaries. Whereas in the blue, we see that the committees are constituted by civil society representatives as well as lay people. So this ongoing research that I've been involved with, which started in 2008, what we've been trying to do is understand, as Professor Michael was saying, we talk about community engagement, but how does it happen? What are the mechanisms? So we tried to trace through participant observation, my field workers in place in India, this transition from non-functioning committees, because just the fact that they're established doesn't mean that they are actually active. So from a non-functioning state to, I would say, a functioning state. And it's never complete. So we cannot say that they are now fully functional, not at all. But some of the key features of this transition or this mechanism, I think, are quite interesting to note. The initial phase, which I would say lasted a couple of years when I look back at our field notes, was more to do with, setting up the committee, the enrollment of members, learning how to conduct meetings, having an agenda, keeping an attendance list, all the kind of organizational aspects which are needed to use the time that was available, an hour or two, remembering that many of these members are very busy, they work on the field, in the farm, etc. The second phase was more to do with raising health awareness. So this would be talks given by a variety of different health workers, functionaries, about village health priorities, trying to co-opt, trying to increase the motivation of the villagers. Together with that, of course, there was also gradually the interest in using the funds. This was about 10,000 rupees, I would say about $130 a year, which the village received. Not a lot of money, but the interesting thing was how that money was used. By that time, noticeable outcomes in the village were seen by the members themselves in terms of clearing the blockage of drains, which was leading to poor hygiene, in terms of improved water sanitation, cleaner water, etc. Now, the third phase, which is where we're still at right now. If you imagine that this research started in 2008, and we're a good 10 years rather on from there. But the third phase of trying to understand the cross-sectoral linkages between the work of the health workers and the women and child nutrition specialists, especially when we're talking about malnutrition, the involvement of the village council is the political arm of governance, the demand for accountability from the villagers themselves, and also this notion of self-help. I hope will come out in the next couple of slides when I'm talking more specifically about some of these aspects. I just wanted to say that with the slide that's coming up, related to the point about trying to keep in mind for the committee to actually focus on how village resources are changing in terms of their status. So here we have an image that was taken from our fieldwork of the committee members trying to identify poor quality of resources. So this could be village taps, which are no longer functioning, they are rusty, or it could be that the water tank is infested with ants. So it was just to show here the ways in which this committee was bringing together and engaging members. So if I can just move on then to our more recent findings, and as I say, this is ongoing research, but our focus is on this notion of intersectoral collaboration for the waterborne diseases, as I said earlier. And here I just want to pinpoint some examples from that. Now, when we talked about sanitation, what we're finding is a much greater responsibility, which is assumed by the village council. The village council, traditionally in the Indian context, looks after all kind of development, community development works, and health was not within their jurisdiction. But now we find that water sanitation is an important aspect of the portfolio of different works, public works that the village council has got to be responsible for. The village council gets a much bigger pot of money. Remember that these small village health and sanitation and nutrition committees gets only about $130 a year, whereas the village council gets a much more substantial amount. So we see this responsibility being assumed. Secondly, the lay community members, that's the ordinary people in the village, are also taking an increasing interest in issues related to sanitation. And this is creating new flows of information between them and with the institutional members, i.e. the functionaries, etc. And in doing so, they are more vocal in demanding action in their village. The VHSNC, as a newly created entity, is beginning to oversee the status of village water resources. So again, it's not perfect, but we begin to see after 10 years, a legitimate body, a body that's seen in the eyes of the health functionaries at the block and the district and the state level as being something that's legitimate. And the VHSNC now monitors, for example, the quality of water at the primary health, which is undertaken by the primary health center. I just want to make sure that I don't run on too much. So, yeah. Okay, if we move on to nutrition, similarly, some very interesting findings. There's a more regular identification of malnourished, especially infants and lactating mothers through house-to-house visits. So these are conducted jointly now in partnership between the health worker and the women and child specialist, one of them taking charge of diagnosis of malnourished children, the other one taking charge of the actual treatment and remedial action. We also see a passing ownership of responsibility onto households. And an example of that, which keeps coming up in our field notes month after month, is how the administration of ORS powder and zinc powder by families and households themselves is taken on board, whereas this used to be something that was carried out by health workers house to house, therefore taking up a lot of their time, etc. And more recently, from 2017, these committees are actually used to discuss, I would say, social phenomenon. One of them being, why is it the case that even though the Indian government offers a healthy meal to low-income women, pregnant women and lactating mothers, why is it that they still have been reluctant to take this up? One of the reasons, of course, relates to social norms. It's not common for a woman to be able to leave her household and come to the center to have that healthy meal. Although this was known amongst the committee, because the committee themselves are villagers, it's nothing new, the VHSNC has been the point at which they discuss and try to make adaptations so that the healthy meal is available through rations, or there's a collection of women traveling together to the center. And lastly, with hygiene, again, there are many similar points that cut across the sanitation and the hygiene. Responsibility has been assumed by the village council for much more major works. Here we're talking about the entire village cleanup. When there's a festival coming, a religious festival, there's a lot more focus on discussing worm infections during the VHSNC meetings, and also the adoption of good practices by households. So there's more of an interaction, for example, between the larva surveys, which are conducted by the health workers, and what the household can do to mitigate against this. Regular discussions about behavioral change. This is an ongoing topic because no doubt the Indian government is investing heavily in building toilets, construction of toilets, but they are not taken up. And so this, again, the committee is the forum for discussing open defecation practices, trying to understand the reasons for why people are reticent to use newly constructed toilets. During COVID, what we begin to see here, and this connects to that concept of everyday resilience that we were talking about, is that earlier we saw how these committees are instrumental for chronic public health. Now we see that because they've been in place for 10 years, they serve as a useful mechanism during the COVID pandemic. And here we see images for how that has actually occurred in terms of disseminating information on the left there in the committee, to vaccinations, to making the point about social distancing at arm's length.
Shireen,
Yeah.
you're running, yeah.
I'm running late.
Yes.
Okay, so this is the last part here. And just to say that I think that the concept of everyday resilience does provide a useful lens. More than anything, for me, it's shown how capacity has got to be built over time. It's not something that leaps out at us. There has been a strengthening of village health governance in our study villages. That's not to say it's all throughout the country. Routine intersectoral collaboration has created this accountability environment for service delivery and has provided a means for people with limited formal power, particularly laypersons, to have a say in decision making. Nevertheless, further research is needed in other country contexts, and also to see how these committees link in a more substantial and sustainable way to the health infrastructure, which hasn't happened yet. Thank you.
Thank you. Thank you, Dr. Madon. So let's move on to Dr. Katabarwa, and then we'll take the questions at the end. Dr. Katabarwa, Moses, you're next. Thank you. Thank you for accepting once again, the invitation. And we're looking forward to your presentation.
Thank you. Today our topic is community-directed interventions approach. Can you move on? Next. The example I'm going to present is on river blindness disease, scientifically known as onchocerciasis. It is a vector-borne disease and considered one of the neglected tropical diseases. It is caused by a filarial worm called Onchocerca volvulus, and this worm is transmitted from humans by the bites of an adult female Samurium or black fly. This black fly or Samurium fly breeds in fast-flowing rivers and streams. So where you expect everything to be pristine, this is where the issues are. Currently, more than 99% of the affected individuals are in sub-Saharan Africa, and outside Africa, currently it's Brazil, Venezuela, and Yemen. Next. By mid-1990s, more than 120 million were believed to be at risk of this infection, and at least 14.6 million of infected individuals have suffered from skin disease, and 1.15 million visual loss. And WHO has earmarked this disease for elimination by 2030. Now, I'm not sure that this is going to happen, but in some countries it will happen. Next. So this is the kind of environment where everyone would want to go for tourism. That's where you would actually find this disease. Next. And these are the countries that are endemic for this disease. If you see those lines in Central America, those have been certified for having eliminated the disease. But in Africa, you can see there is still a problem. Brazil and Venezuela, there is a problem. You can see Yemen there in the south of the Saudi Arabia, I guess. Next. So there are a number of interventions that are known to to deal with this problem. And you can provide ivermectin. Ivermectin is a medicine provided free of charge by Merck company, and you can distribute it once or twice yearly by height because normally medicine is given by weight, but if you're going to treat millions of people, having those scales to go around every place is not an easy thing. It's actually difficult. So we use height using a measuring stick. And then some have used vector control. This is a vector-borne disease where things are tough and you want to shorten the period for interruption of transmission. You can apply ABET, which is a biodegradable agent, kind of approved by WHO, or you can do slash and clear of the vegetation around the communities, but I will say more about that. Next. So to control this disease or to interrupt transmission of this, you need to treat all the eligible persons, those people who are 5 and above with 5 years of age and above with ivermectin, and you have annually or biannually with at least 90% of treatment coverage or 100% geographic coverage. We here mean the number of communities that are affected. It takes about 7 years to interrupt transmission with biannual treatment with ivermectin, and it's not clear how long it takes with annual treatment. There are many other factors involved. Shortage, of course, when we're talking about treating affected communities, everyone discovered that there's a shortage of workers because these we're talking about millions of people treat every year. And already the health workers are busy at the health units serving patients that are coming to be taken care of. Then another thing is timely reports on treatment and the medicine used every round. You need to report that, and then the country has to apply for the next consignment of ivermectin. Ensure that, then you need to ensure that when people are getting this medicine, they are directly observed, not just giving someone 2 tablets and they go home, take it. No, they take it there and then. And of course, expecting mothers are treated a week after delivery. So in many cases, when communities were involved and health workers were involved, we discovered that the community members are outperforming the health workers. And that shocked many people who believe that to get formal education, you are doing better than the guy who never really went to verify in formal education. Next. So there was resistance. In ministries of health, clinicians, medical doctors would say medicine should be handled by clinicians, not these uneducated people. Community members live and operate mainly in unhygienic conditions. How do you give them medicine? How do they handle the medicine? Moreover, community members were not expected to follow standard operating procedures. That's what educated people believed. Then they are likely to hurt themselves with ivermectin, commit suicide by taking medicine, because it's at home, and if you quarrel, a lady quarrels with her husband, just says, now I'm going to finish my life. I take ivermectin, so they kill themselves. But what we forget is that, especially if you are from Africa or even other countries like South Central America, you will find that your mothers and grandmothers are not highly educated, and yet they are the ones that have sustained you. Some of us who are here being considered as highly educated people, really our mothers never went to school, but we are here because of them. So this was not happening only in Uganda, it was happening in other countries. And so WHO, there was a meeting somewhere in around 1993, and they say, okay, how do we overcome these two schools of thoughts that could not compromise? Let's have a study, a multi-country study, finance it, and see what the outcome of the two approaches. Next. And so during this preparation of this study, they defined what the community-directed interventions should be. That community members collectively discuss the health problem and the possible intervention on the basis of information provided to them by the initiators. Community members collectively design the approach to implementing the intervention in the community and identify the resources to use. So everything was really talking about the community being empowered to do all these things after they have been provided the information they need. And the desired treatment coverage was at least 90% of the eligible population and 100% of the communities in the area covered. And
sorry, Moses, sorry to interrupt. Just to say you have 5 minutes, if it's possible. Thanks.
Yes. Okay. So what is going on here is that the communities proved successful. And then WHO had no choice but to allow them to this approach to go on to be promoted. Next. And so, but we found a few things that were not happening the way we expect. So another study was launched, and to study what is going on within the community, because what WHO had approved was what we call the classical CDI, or community direct intervention, and we wanted to see if we use the kinship, because in Africa, communities are organized around their kinship systems. So next. So the blue side is the classical, where you are not thinking about the kinship, and the red side is where the kinship is introduced. And you can see that in terms of behavior, the kinship side, or the arm of the study, was responding very well. Next. And then when we talk about policies, in the red, the policies were promoted and many people participated in laying down the policies. They are down here on the x-axis, and they performed better than what we usually call community involvement, that is normally brought down by the government system or NGOs or any other groups that come to the community. The kinship enhanced CDTI or CDI did better than the classical one. Next. And again here, the distributors of these medicine, we call them CDDs. You can see in the kinship side, which is the red side, they are doing very well compared to the other side. So the kinships enhanced CDI really performed better than the classical one. Next. So there were issues that we used to argue about. Should communities train the distributors of the medicine? Do we need to train them in the community under a mango tree or somewhere in a school, in a building? And personally, my preference was train them where they are. That's under a mango tree or in any other place. And that's convenient for mothers to be involved. And but when you take them away from their homes, you are putting a lot of stress on them. Next. And you can see, because that was done at the kinship level, you can see now women who never used to get involved are involved distributing the medicine within an area they understand, they are convenient to their domestic chores and other things. And so women who were not involved before, now you almost have 50% of the distributors of the medicine as women. Next. And this is in the pandemic, during the COVID-19 pandemic. You can see these, some of these are distributors, and they're distributing the medicine, and actually they achieved the same, they performed the same way as before the pandemic. Next. This is slash and clear, which I had mentioned, where communities are slashing the vegetation and clearing it. And this is where the flies, the black flies breed. But when you clear, it increases the temperatures and causes these flies not to survive easily. And so it reduces the biting. And so these communities are doing it without asking for money from government or expecting this or that. For them, it is their health. Next.
Since we need to,
yes.
End.
Okay.
If you can, yeah.
Okay. So this is the area where the slash and the red, where slash and clear is being done in northern Uganda. Next. And so here, let's go to the next one so that you can see the next. You can see the red, the map with the red areas. That's how Uganda looked like as far as the onchocerciasis disease was in 2007. But here in 2022, this is the situation. And this is really the success due to the community involvement. Next. So in conclusion, the treatment coverage satisfaction with the program in kinship enhanced CDTI or CDI was significantly higher than in classic CDTI projects. Participation of community members in deciding on community policies was higher in kinship enhanced CDTI than the classic CDTI project. Utilization of the traditional kinship system resulted into increased community involvement, reduced workload, distance to work in the community, period of ivermectin distribution within a week for most CDDs. CDs working among people who were significantly relatives. And that really made things improve. Next. So we recommended that the CDI should actually utilize the traditional kinship system within the community in order to improve its efficiency and effectiveness. So this has been next. This has been this has worked in Uganda, but we have tested it in Ethiopia, in Nigeria, in Cameroon, and in Sudan, and it works. And so thank you very much for your attention.
Thank you, Dr. Moses. I mean, Katabarwa, that was a really nice exposition of how we can bring in the community and maybe enhance, the delivery of programs. So we've got two questions. Maybe we should take the questions first, and then we can round up, as a panel. Are you both okay with that?
Yes, sure.
That's fine.
Okay. So because I think people will leave, this is scheduled for 1 hour. So one question that has come up is addressed to you, Dr. Madon. And this is the question which has been asked is, what are the biggest challenges faced when developing a functioning VH-SNC in India?
Mm-hmm. Yeah, thank you. I saw this question. Thank you very much for this question. And that is a great one. There are so many factors, as we can imagine, but I would say that when I trace back, I would say that it's been the slow support, growing support of the village council. Remember that the village council, the president of the village committees that I talked about is a politician, is a village council representative. Now, initially, it was the case that the village council was somewhat detached from the village health committee. And that meant that the village health committee was pretty much a standalone small unit, but it was neither well connected to the health apparatus, because I remember going to the PHC, to the primary health center, and the medical officers were not at all interested in this research. They said, yes, that's a social determinants of health. It's not so much about, health from a biomedical point of view. And they sent me away. So it was neither well connected, although institutionally, the entire VHSNC scheme was under the Ministry of Health. Yet locally, there wasn't that cooperation with the primary health. So I would say that it was the increasing co-opting of the village council that has made these committees move from being non-functional at one point, just there in terms of the label, to being regular mechanisms for bringing together the community and meeting monthly. I mean, they run monthly meetings now.
Thank you, Dr. Madon. I think we'll return to this question, later on as well. But we have two questions actually, which is asking about the role of women. So let me give this first to Dr. Moses. And you have 2 minutes. And this is saying, the question is, you noted women were an important part of the strategy. What are women's roles within the kinship that allowed them to participate?
Women's are 100% in charge of health. They are almost 50% of the population. So when you don't consider their issues, you are simply ditching whoever you are dealing with, the community you are dealing with, because men are not involved in health. Women are. And so it's important that they get involved. And the things that stop them from getting involved should be looked at so that whatever they do is as convenient to them as their great grandmothers were.
That's, yeah. And Dr. Madon, a question related to India, gender, right? That women continue to have a lower status, social status than men. So in terms of women's agency, in the communities that you worked with, how did you get women involved? How did you transform society accepting women's authority, so to speak? Yes. Especially men.
Yeah, right. I mean, the formal structure of these committees was 33% women membership, and women membership meaning the health workers as well as the other functionaries as well. But it's one thing having things written down on paper, and it still is not the case that in every committee there are women who are vocal. The other big question that we've always faced in our research is, what about village dynamics? Which women take part? Is it the truly marginalized women? Well, we have not been able to study village dynamics from that ethnographic point of view, which we'll try to follow up with. So I think that there is an increasing role and presence and vocal presence of women in the committees, but it is space to be watched.
Yes.
Yes, Moses. Yeah. Okay. So one question, a general question to both of you, right? When people talk about, engaging the community, they always have this discussion, medicine or the practice of medicine, I think Moses touched upon this, is highly technical, and, you need experts. The knowledge is within the experts, so to speak. And that community do not have the knowledge, and therefore, is it possible to engage the community to deliver a healthcare system, because knowledge is asymmetrical. So what would you respond to that kind of critique? Moses, do you want to start? Yeah. You're muted.
You know, I'll give myself an example here. I never went to the maybe my mother took me to the dispensary at some point, but I rarely read in my primary school when I was young, as I remember. But my mom would actually bring some medicines. You know, I mean, you have these shopkeepers who sell medicines also. But once she is told that this is the tablet for this and that, and this is the number you give to this child or whatnot, she followed. She never went to school. She treated us for malaria. We had quinine those days. And she treated cough. If it was not the traditional medicine, the herbs, she used the medicine from the dispensary as she was told. So I'm here, and my brothers are there, my sisters are there, and the village also, there are many people who have gone through this system. So they have knowledge, they have the brain. If they are told, they can deliver.
Mm-hmm. So Sharon, do you want to say something? You know, I mean, you mentioned that they brought up sanitation organically as a problem that the community wanted to focus. So do you want to expand on that?
Yes, I mean, I would say in response to that very interesting question is that even though the health specialists have got knowledge of indicators and how to measure it, if we're talking about the social determinants of health and recognizing that, you know, health is, at the end of the day, it's a social function, there it's the community that can answer why is it the case that the incidence of diarrhea or typhoid or any other disease is increasing or reducing. Because if it's the social determinants that lives within society and community.
Yeah, so I mean, so this comes to another question, right? Educating, I mean, both of you touched upon the importance of, you know, educating, learning, you know, as a process of engaging the community, because many communities are also suspicious, shall we say, of modern medicine. So, you know, we need to somehow engage with them. And it's a learning process, you know, which takes time. And yet, if you see donor-driven programs, which many of these countries are engaged with, there's an urgency, there's a time element. So do we have enough time to get the community, you know, developing or engaging or understanding the community perspectives before we can actually bring in the community into health programs?
Well, I mean, I would say that that's the thing, that the evaluation, there's a lot of monitoring all the time, but evaluation and learning is always something, not just in the health sector, but in development in general, which is lacking. So you have no end of mHealth interventions, even in the place where I'm researching right now. But what does that do? It's transient, and it doesn't really create that kind of resilience and sustainability we are talking about. Yeah.
So Dr. Moses, Katabarwa, sorry.
Yeah, we train people from kindergarten to university and graduate schools and whatnot. We are patient to do that. Why can't we be patient to spend a month or two educating the community that where these kids or where these kids are coming from? And so if we have not patient enough to educate the majority in the village there, what do we expect? How are we going to control Ebola? How are we going to control COVID-19? How are we going to deal with this disease, emerging disease? Some of them we know, some of them we don't know yet. How are we going to control TB? So if we are not patient enough to train or to educate our people in the community, then let us remember that these diseases will come to us.
Yeah. I mean, the other issue with community engagement is also this: will they be engaged long term? I mean, I know, we all have other things to do, as members of a community. We're not experts in health. We've got other, that's why we have a Ministry of Health, right, to look after health. So why should, so does the community have the what's the word, sustained, interest, in actually transforming health in their lives? Because, they've got other things to do. How would you engage them in that way? Time is limited for all of us. That's why we give those kinds of jobs to politicians, for governance. We give those jobs to our health ministry, so that we don't have to do that work.
Well, health is the responsibility of every individual. You don't expect the doctor to come to my home telling me how to live. But if I am taught how to live and do better on certain things, then the doctor will not see me in his hospital or in their clinic, because I will take care of some of these things. So health should also be the responsibility of an individual, not for people who are in the Ministry of Health. And coming back to politics, I mean, that's why there is a lot of wars and whatnot, because we have handed over our political management to certain individuals, and so I keep it at that.
Yeah. So, Dr. Madon, do you want?
Yes, I mean, with that, is that exactly what Dr. Katabarwa was saying, that there are layers and layers of responsibility there. Here we find that the village council has assumed so much responsibility. Then there's that small village committee, but then there are the households as well. We can see this layering of responsibility and accountability, a different type of horizontal, if you like, or village accountability amongst the villagers themselves. Now, it all sounds very romantic that everyone is accountable and everyone is engaged, but I think that these things have got to, there has to be time to let it evolve.
I mean, I want to end with last, I think we're running out of time, question. I mean, do both of you then think that we need to change governance? That health is part of, as you said, it's a social construct, right, ultimately, and also is part of development. I mean, I will give you one anecdote, So when I was working in Tanzania, we went and gave pills, to people for lymphatic filariasis. And then this lady came up to me and said, "This is great that you are helping treat our people, but can you get my son a job?" So that touches upon, that stopped me. I was only a postdoc at that time. That began for me, what do we need to do? Because societies know, in a way, they know what is causing harm to them. And that is lack of opportunities, poverty, those kinds of things. So how do we change the governance, health governance structure so that, VHSC, the village health committees is one forum, right? That we can bring in, change the governance of health so that we can also address these deeper issues which are actually driving health conditions of people. What would you, both of you, how would you, go about developing such a structure?
Well, yes.
I would just say that it has to be multidimensional. There must be a multidimensional approach. How are we training our health workers? Are they trained to go and be saviors of people who can't help themselves, or they are going to be trained to train those that are at risk of contracting diseases, spreading diseases, so that they can stop doing it? If I am a trained medical doctor and I get a patient coming to my clinic, am I only going to just use those machines and whatnot to look at, and I never tell them what they are suffering from, how they should have prevented it, or how they can prevent it? that's one thing. When you talk about this, the government structure, the Ministry of Health and others concerned, do they come with an attitude that communities are also an interested party? Or you want them to come and listen to your rules and regulations and your bureaucracy? I think they need to know that people have a stake in health, and they are the majority. We are talking about over 95% in some countries. So if you neglect them, then you're actually only increasing public health problems.
And do you want to say anything? I mean, how do we change the structure?
Well, yeah, I mean, that's I think Dr. Moses, will really spot on, because you have policy intents, like the VHSMCs are well thought through policy-wise. Then you have the instruments, which are the committees themselves. But that's not enough. The field of action, where things actually happen, the enactment of that policy is always on the ground. And that on the ground is that lady responding by saying that I want my son to get a job. So that, the point being that learning from policymakers to learn, and the agenda setting for policy does not end with the intent of the documents.
Problem with government, governance currently. I'm talking in particular about health programs in developing world. I was involved in lymphatic filariasis control programs, in Africa. So, for example, when we told them, filariasis is spread, and I know Dr. Katabarwa will have an opinion about this, is spread by mosquitoes and therefore you have to take, and this was a drug administrative program. We were giving drugs to control lymphatic filariasis. And yet we were telling communities that it is spread by mosquitoes. So the community members were asking us, if it's spread by mosquitoes, why don't you stop? Why don't you have a program that kills mosquitoes? Because for them, mosquito bites are a bigger nuisance. So this, many ministries of health and health programs cannot change their structures. And this is because these are donor driven. They are given some indicators. You have to treat so many people and that's it. There is no leeway for them to do experiments, to bring in, for example, vector control. So it doesn't make sense to the community saying you have a mosquito-borne disease and yet you're not attacking the mosquito. You're telling us to take a drug. And that brings in all kinds of suspicions. What are these drugs for? Why aren't, so there's a tension between what the community can understand or the perspective of the community and the needs of the community versus this very top-down programs which are narrow in focus, and the ministry people have to just meet their targets. So how would you change that structure? And I find it very difficult. And Dr. Katabarwa, you can tell us a little bit more on Slash and Clear, where the community is taken charge of interventions. When WHO doesn't have vector control, up till now for onchocerciasis, and yet you've introduced vector control in Uganda through the community.
Actually, WHO at first in the 50s, 60s, 70s, WHO promoted vector control, but they promoted it at a very expensive level. But later on, when ivermectin came, they thought, okay, this is now the magic bullet, and we are there. But even then, when you are talking about larviciding, there are cheaper ways. Depending on where you are, they used to use planes to do the larviciding for vector. That's vector control. But here you can actually use communities. If you train them, you can use them, and it's done cheaply and conveniently. In 2017, WHO has again accepted vector control. There are documents that they have produced, but again, we need also to educate the donors. I wouldn't blame the donors. Because they listen, and whomever they are listening to, whom they think that is an expert, they follow that. But I think we need to educate the donors, and also the donors need to listen to those whom they are supporting. And so the donor used to deal with the agency and NGO, whatever, but I think it's also important for the donors to have an experience of what goes in the community. Yeah.
Okay, so last question I'll have is, if we have to wrap up, is Shireen, I mean, you talked about policy, Indian government policy to allow the space to develop. Was there resistance, from the other parts of the administration saying that, for example, the village committees are becoming too autonomous, are taking decisions which does not lie within the remits of government objectives?
Yeah, definitely. And at the district administration, for sure, that the district is very powerful in terms of resource allocation, drug allocation. And there has been a period of resistance. There was also a period of withholding the 10,000 rupees, the funding for the villages. But it was because of the tangible improvements when there was an outbreak of diseases, the tangible improvements that could only happen through the village-based committees in curbing the spread of infections, that again, over time, it's become realized that the committees are very useful.
Mm-hmm. And so what is the policy change? Is the government going to change the policy to involve this kind of local decision-making bodies?
Yes, they are doing that. They're giving more power to the primary health center. This is something that goes back to Alma Ata, that we all know, but it never actually happened. It always stopped short at the district administration. So now there is more effort, not just money, but there's more leeway and guidelines for the VHS, for the PHC, primary health center.
Well, thank you, both of you. We can go on and on this topic, but I think we have to wrap up. People, other time pressures and things. So it leaves me to just say thank you so much for both of you to come on. And with that, I think thank you, and then we'll leave it at that. Thank you so much.
Thank you.